Our next speaker is Dr. Stephen Deputy. He's our newest neurology faculty member here at Dell Medical School. Stephen joined us in January, I believe, after completing his training in child neurology at the University of San Francisco, or University of California, San Francisco, UCSF, and has spent most of his career until joining us in New Orleans, where his concentrated interests are in medical education, curriculum development, and from a clinical standpoint, movement disorders. He's going to update us today on tics and Tourette syndrome, right? Thanks.
I'm happy to be here. I think this talk, or not the talk, but the topic is very important for primary care pediatricians because tics are common. You're going to see them. You're going to see them, a lot of them. And what do you need to do with them? How do you counsel people that have tics? Hopefully we'll have some answers for you at the end of this talk. Right now, I don't have any relevant disclosures, so we'll just skip over this. So we want to be able to differentiate different tic disorders. We want to be able to counsel people to understand the natural history of tics within Tourette syndrome. There are an awful lot of neuropsychiatric comorbidities in most people with Tourette syndrome, and I think these need to be identified and recognized. As we'll find out, they often are causing much more psychosocial disability than the tics per se. We need to prioritize which features of Tourette syndrome need to be managed initially to come up with a treatment plan, and then we'll talk a little bit about some of the principles behind pharmacotherapy and comprehensive behavioral intervention for tics, which is a habit reversal therapy. So what are tics? I think we all can see them, we recognize them. The definitions are, they can be motor or they can be vocal, but they're rapid, repetitive, non-rhythmic, stereotypic. You see one tick, you see the next tick, you see the next tick. They're always the same, right? An individual tic doesn't change. They can be these movements, but they can also be vocalizations. They often occur in bouts. They wax and wane in frequency, intensity. New tics replace old tics. Old tics can come back. We can have multiple overlapping tics. So they're very dynamic in that fashion. The other thing about tics is that they can often be temporarily, voluntarily suppressed unless they're very, very severe. So somebody may bring their child into the office and say, I think my child has tics, and you won't see any in the office. That doesn't mean they don't have tics. Another factor about tics in older kids is there may be a premonitory urge, a sensation internally that occurs just prior to the tic being exhibited. And this is going to be important when we talk about the habit reversal therapies. So motor tics arise with involuntary musculature. Think about head and neck regions. And tics usually begin with eye blinking is really common, or eye darting movements, or facial grimacing, or head jerking movements. Same thing with the simple vocal tics. They're going to be repetitive sniffing, repetitive throat clearing. Well, there's a lot of kids that have allergies. They sniff, right? So what differentiates that? Sometimes it's tricky, but one of the things about tics I always tell people is that they're things that we all do. We all sniff, we all blink our eyes. But if it's repetitive and excessive and it's not serving a function, that's what makes it a tic. And the other thing you can do with tics is that they're not going to be there for a week and go away. They're going to wax and wane, and they're going to become more prevalent when there's stress or excitement. So those are some clues as well. This is just a little side thing, but we've been seeing these functional tic disorders lately. And these are kids that are exploding with these very complex motor tics and vocal tics and corporalia out of the get-go within a few days. Tics and Tourette's don't do that. They start off in the face, and then over months or years, they can progress down to the extremities. So that's something to keep in mind as well. The motor tics are basically, the vocal tics are anything that comes out of the nose or mouth. So sniffing, guttural sounds, humming, hooting, little noises, up to complex vocal tics, which are formed words, and then we have this corporalia, right, where we're shouting out curse words. Well, one of the misunderstandings of Tourette syndrome is that corporalia isn't required to make a diagnosis of Tourette syndrome, and in all patients with Tourette syndrome, no more than 10 or 15% ever experience bouts of corporalia, so it's fairly rare in Tourette syndrome. All right, so once we've identified that a child is having motor or vocal tics, then we need to look at what is the classification of their underlying tic disorder. So we have a kind of a hierarchical pattern, and I think the best way to think about things is we have a transient tic disorder or provisional tic disorder. By definition, means that the tics have been present for less than 12 months. Chronic tic disorders, by definition, mean they've been present for greater than 12 months. But as you can probably recognize, everybody with a chronic tic disorder at some point in their tic history was going through a provisional tic disorder, right? So one of the things I think I like to try to do if I see somebody who's only had tics for less than a year is I want to help the family understand what's the likelihood that this is going to become Tourette syndrome versus what's the likelihood that this is going to remain a provisional tic disorder. So that's something to think about as we move forward here. If we look at the frequency in the population or the prevalence, as many as 1 in 5 children experience tics at some point in their life. 20%. That's a lot of kids. That's why you're going to see them in the pediatrician's office. But if we look at the prevalence of Tourette syndrome, you'll see it's much less common, 1 in 150 or so. So the vast majority of kids that are presenting with tics are going to have provisional tic disorders. And I think that's important to counsel the families with. So the definition for Tourette syndrome is that you have to have multiple motor and at least one vocal tic off and on for greater than a year. The tics are going to wax and wane in frequency and severity, as we mentioned. Age of onset needs to be before 18 years, but often is much earlier in life. And the tics are not caused by a secondary disorder. Which are rare, but disorders that we have injury to the basal ganglia, things like Huntington's disease, people that recover from encephalitis, autism, interestingly. About 30% of kids with autism have tics. So I don't call those people having Tourette syndrome and autism. I say they have tics within their autism disorder. There's gender influences. There seems to be a strong male to female influence in chronic tic disorders, but also in the provisional tic disorders. And within the chronic tic disorders, there is an increased background family history of other people, first-degree relatives with tics. That's much higher than in the general population. There's not a gene that has been identified that causes Tourette syndrome. It's been looked for. It runs in families. It's multifactorial. It's a mess. They keep looking and looking and looking. They can't seem to figure it out. But it's very common to ask if there are other first-degree relatives or second-degree relatives that have tics. So one of the things to counsel families about are what's the natural history of tics and chronic tic disorders? Well, the peak age of tic recognition is usually early school age, although if we look at studies and we go back in time and we maybe that wasn't allergies, or maybe that child didn't have allergic conjunctivitis, and maybe that eye blinking when he was 2 or 3 years of age was tics. They can occur in toddlerhood or occasionally in infancy. The tics start off, and everybody's a goofball in first grade and kindergarten, so the kids don't stand out. They're not having any awareness that they're even having tics. The parents are more concerned about the tics than the kids are. But tics tend to peak between 10 and 12 years of age, like 5th, 6th, 7th grade. And that's partially due to the fact that kids at this age are becoming more self-aware of how others, their peers, are seeing them and are reacting to their tics. And they start getting self-conscious about their tics. They start getting embarrassed about their tics. And so what do? They try to suppress their tics. Well, that's stressful. And when you can't have tics in school because it's embarrassing, you're going to build up these tics inside. And it's very important for the families to recognize when the kids get home from school, open up that pressure cooker. Let them have the tics. Don't draw attention to the tics. Don't talk about the tics unless the kids want to talk about them. Have the teachers know, just ignore the tics. The more you point them out, the more self-conscious the kids are, the more stressful they are. They're trying to suppress them. That stress causes more tics. More stress, more tics. It's a vicious cycle. So I like to have what we call a tic safety zone at home, where nobody's asking the kid about the tics. We've got to talk to the parents. We've got to talk to relatives. And who's going to talk to the relatives? Who's going to talk to the baseball coach? The parents are. So education here is really important. I want the parents to be educated so that they can advocate for their children. And if we do a good job with this, and we normalize what this looks like to the child, by the time they're an adolescent, it's not a big deal. Everybody knows that Johnny has Tourette syndrome. They want to talk to him about baseball or something else. And so Johnny doesn't have to feel self-conscious about those tics. And so we're less stressed about the tics, and guess what? They get better. And if you look at the natural history of tics, when we get into adolescence, 1/3 of kids will stop having tics for the rest of their life. Another 1/3 will have a significant improvement of tics, and another 1/3 will continue to have tics. So I'm in this for the long run with the kids and the family. I want to do a good job. I want the parents to be able to advocate for the kids when they're younger. I want the children to be able to advocate for themselves when they get older. So that's why I recommend that the children themselves read up about Tourette syndrome, kind of embrace the fact that they have Tourette syndrome. Don't be ashamed about this. Don't be embarrassed about this. And learn about how to answer, what is a tic? You need an answer. What is Tourette syndrome? You need an answer because mom and dad aren't going to be there all the time for you. So with that being said, let's talk a little bit about some of these other neurocognitive and neuropsychiatric comorbid disorders associated with Tourette syndrome. And probably the one that comes up the most is ADHD, because up to 70% of children with Tourette syndrome have clinically significant ADHD. And I think it's important to recognize that, especially ADHD combined type with hyperactivity, those symptoms are going to be present before the first tics are recognized. And if that's the case, what are you going to do? You put a child on a stimulant medication for ADHD, and what happens? 6 months later, a year and a half later, they start having tics. So everybody assumes that the stimulant medications are causing the tics or are worsening the tics. And in fact, what we're going to see, and there have been some very good studies that have been looked at in a very careful, blinded, placebo-controlled crossover trials of children with Tourette syndrome and ADHD. And in fact, stimulant medications do not exacerbate tics in the vast majority of children. So I treat ADHD in kids with tics exactly the same way as I treat ADHD in children that don't have tics. And if they get a tic exacerbation, I'm not going to change the stimulant. I'm not going to try to work with non-stimulant medications that aren't as effective for the core symptoms of ADHD because I'm worried I'm going to make the tics worse. And I think if there's one thing I would like primary care pediatricians to take home, it's that message. Because so many of these kids are not managed appropriately for their ADHD symptoms. And sometimes that makes the tics worse because the kids aren't doing well in school. And sometimes you put them on a stimulant and they're succeeding in school and their tics get better. So don't be afraid of using stimulants in children with tic disorders if they have clinically significant ADHD. There's higher background rates of learning disabilities and learning differences in children. And learning disabilities can be complicated by ADHD. And for those of you that take care of kids with ADHD, you recognize they also have a lot of executive function difficulties. And that can exacerbate learning disabilities. They're disorganized, they don't have good time management, they're not prioritizing what they have to study. So working on executive function skills is very important for kids with ADHD, whether they have Tourette syndrome or not. Anxiety is probably the second most common thing I see with Tourette syndrome. And as we talked about earlier, anxiety and stress can make tics worse. And so sometimes working on the anxiety actually makes the tics better. And that may be an approach if we're not making progress with pharmacotherapy for treating tics with typical tic medicines. Sometimes I'll shift gears if it seems like this child has a lot of anxiety, and we'll treat their anxiety and see if that helps with the tics indirectly. Phobias for kids with anxiety can be exacerbated by their tics. They don't want to go out in public because they're already anxious about going out in public. And then if they have a generalized anxiety disorder, it just makes everything worse. OCD, obsessive compulsive disorder, actually is sort of rarer, but obsessive compulsive behaviors are really common in children with tics. Evening up, counting, needing to be organized. And we need to recognize that anxiety drives obsessive compulsive behaviors, and so those guys can interact with one another. The need for washing our hands and germ phobia is much less common in the OCD that we see in Tourette syndrome than the OCD we see without Tourette syndrome. Mood disorders are becoming increasingly recognized. There's an increased risk of suicidality in children with Tourette syndrome, and so this needs to be screened for as well and possibly treated. Poor self-esteem can be an issue as well. So last little bit to talk about our treatment for tics. First take-home point, most kids with Tourette syndrome don't need to be put on medicine for their tics. We need to do education, we need to have our tic-free zone, we need to advocate for them, normalize this for them. But I'd probably estimate about 20% of kids I see with Tourette syndrome I'm actually needing to use, to intervene for the tics themselves, above and beyond education. Recognize that tics should only be treated if they're causing significant psychosocial dysfunction for the patient, not mom and dad. Like I said, I never treat kids in kindergarten, first grade, because they just don't care. They just don't stand out. So, but you know, 5th grade, 6th grade, 7th grade, high school sometimes. And we have kind of two approaches. We have psychopharmacotherapy and CBIT, which I'm going to come back to the pharmacotherapy in a minute. So my approach to seeing a child with Tourette syndrome is the first thing I do is we talk about their tics, and we kind of grade, you know, how severe are the tics, how disruptive are the tics. But then we're going to screen for anxiety, we're going to screen for ADHD, we're going to screen for OCD, we're going to screen for mood, etc. So I understand all the issues that are going on with the child. Then I got to rank them. What's causing the greatest degree of psychosocial dysfunction? If it's tics, we're going to treat the tics. If it's ADHD, we're going to treat the ADHD first. If it's anxiety, we're going to treat the anxiety first, and then we're going to let the dust settle. We don't want to try to co-treat 2 or 3 things at the same time, because sometimes you treat something and something else gets worse, or sometimes you treat something and something else gets better. The Tourette Syndrome Association has a wonderful website, and I encourage parents and kids to go to that website to learn more about tics and Tourette syndrome. That's a really good resource for them. I think that it's important for people with Tourette syndrome to know that they're not alone, that there's a lot of people that have Tourette syndrome. Kids with Tourette syndrome grow up to become adults with Tourette syndrome. Adults with Tourette syndrome can do just about anything. I like to give the example of the surgeon that goes in and does an operation and doesn't have a single tic during that complicated procedure. and then he has to go to the doctor's lounge and kind of get the tics out of their system. So people are musicians, they're airline pilots, they're surgeons, they can do just about anything. The local Tourette syndrome support groups are very helpful as well for the families. And then the last thing I want to talk about really quickly is treatment of tics. There's American Academy of Neurology guidelines that came out in 2009 with different levels of evidence. And basically, education, education, education. Probably one of the most important interventions for treatment of tics is this CBIT, this Comprehensive Behavioral Intervention for Tics. And this is a habit reversal therapy where the kids learn to recognize those premonitory urges, and once they can constantly, consciously recognize that premonitory urge that occurs just before the tic is exhibited, they do a counter movement. Maybe it's circular breathing, maybe it's holding their neck down, and they hold that counter movement until that premonitory urge goes away. And you have to do this with one type of tic at a time. The advantage of this is that there's no side effects, and they can take this with them. They feel they have some control over their tics, and that's really, really important for them. It's usually about 6 or 7 weekly sessions, and then they may need to come back for 1 or 2 sessions periodically. Unfortunately, this is an intervention that is not widely available in the Austin area, and I hope that over time we can get a few more providers for this, because this should be first-line therapy for anybody that needs intervention for tics. As far as medication goes, the AAN guidelines do recommend alpha-2 agonists as first-line treatment. That's your guanfacine and your clonidine. I kind of find they're wimpy tic medicines, but they're very well tolerated, and that's, I think, why they're first-line treatment. The more effective and more potent tic medicines are neuroleptic medications. And the reason they're not first-line is because they're not as well tolerated. And if you look at evidence-based medicine, which is what these guidelines come up from, these are old studies with these medicines, and they're putting kids on 5 to 10 milligrams of Haldol a day. Well, of course they're not going to be well tolerated. So I use typical neuroleptics like flufenazine or haloperidol, or atypical neuroleptics like aripiprazole or risperidol. Little tiny dosages. We don't get into extrapyramidal side effects. The main side effect that limits dosing is sedation. And I try to build them up. Like on haloperidol, my maximum dose a day is going to be 2 milligrams. It's going to be 1 milligram twice a day. It's either going to work there or it's not going to work. And what I like doing is building them up to a dose where we have an improvement in the severity of the tics without causing side effects, but not necessarily stop all the tics. And then when they're doing well, I try to gradually take them off. And then if we have a bad tic exacerbation, bam, we can go right back on. So coming on and off low-dose neuroleptics is what I like to do for most of these kids, because if they're already on 2 milligrams of haloperidol a day and they have a tic exacerbation, you're stuck. So it's always better to go off and on. Kids that have really, really difficult to manage tics are very difficult to treat. Kids that have mild tics don't need treatment at all. So it's these ones in the middle that you can probably make the best difference with. And I think with that, I'll stop and see if there are any questions. Oh, thank you. We have a question up front here.
Great talk, Dr. Deputy. I had a question about distinguishing functional tics, which you started to touch on, versus physiologic tics, because I really struggle with telling the difference.
Yeah, so they're called TikTok tics, right? Because TikTok is a social media app where there have been several adolescents, usually, that are portraying their Tourette syndrome and filming it for the benefit of the world, so that we all have a better understanding about what Tourette syndrome is. So functional tic disorders, as I mentioned, are explosive in onset and are usually composed of a variety of complex motor and complex vocal tics. directed behavior, self-injurious behavior. Coprolalia is really common in this group. And abrupt onset. And yes, you can see all these things in chronic tic disorders, but you want to go back. Did you have those simple tics? Did you have eye blinking or facial grimacing or head jerking or sniffing tics or throat clearing tics that over years have gradually evolved into these dramatic, multiple complex motor and vocal tics? That's Tourette syndrome, not no tics and then all of a sudden, bam, we're having these complex tics. So that's the main thing that I use, but it's phenomenology. And there are some new articles coming out in the literature about the phenomenology that can differentiate the two. Okay, thanks. Yes?
I wanted to ask a quick follow-up to that. We've been seeing a number of patients who get sent to the ER for especially these rapid onset complex tics that become quite disabling, especially with the rapidity of onset. What advice do you have for the sort of short-term immediate management of these patients?
Yeah, I think if you're really stuck and it's really bad, benzodiazepines, a little bit of clonazepam to maybe take some of the anxiety down, because it's usually anxiety that's driving a lot of the tics. Okay? I'd like to bring up one more thing too. PANDAS is this disorder, psychiatric autoimmune neurological disorder associated with strep, is very controversial, and my preference would be that we not check ASO titers in somebody that comes in with new onset tics, because that's going to create a big maelstrom. You can take that or leave it, but I'm not a big fan of PANDAS. Yeah, I think we have a question in the back. Yes, ma'am.
Yes, I have some follow-up to the anxiety tics, and sometimes these kids are progressing to like almost to pseudo seizures and a lot of just somatization. And I wondered what your experience with that relationship is, and if what the utilization of early on when you first see the tics associated with anxiety, like treating with like an SSRI or something, trying to manage the anxiety before they get to the point of the pseudo seizures.
Well, anxiety itself is different from conversion disorder, which is a non-epileptic seizure, but they can go hand in hand, obviously. But I will use SSRI as a first-line therapy as I'm going through my tic prioritization. Or do we have a lot of anxiety? Are anxieties driving tics? I'd rather use an SSRI there, actually, than to put them on a neuroleptic medication, because I might kill two birds with one stone. So I think that we should think about anxiety, and I think we should treat anxiety, and I think it's a priority if it's there. It's those kids that just have tics or have predominantly tics that are disabling, that don't have a lot of anxiety. Those are the ones that I'm going to be using neuroleptics for as first-line treatment, if that answers your question.
So you don't really find that there's a relationship between tics and conversion disorder?
I do not. They are separate issues. Just like anxiety and conversion disorder are separate issues. Not everybody with conversion disorder has anxiety, but the rate of anxiety is higher, but they're not causal. They're just an association. Those functional tic disorders have a lot of anxiety with them. They're almost like a conversion disorder, but oftentimes they have anxiety, but not always. So it's just kind of a new phenomenology, and that's the goal of the psychologist, is to do the cognitive behavioral therapy for anybody with conversion disorder, but they also need to screen for anxiety, and if there's anxiety or mood disorders, those need to be treated separately. Yep, thanks. Yes, sir.
So, comment on the use of nicotine patch for tics.
All right, so there's a lot of medications and interventions that have been touted as being useful for tics. You can read about just about any medication makes tics better or makes tics worse, and part of that problem is we're dealing with something that waxes and wanes and fluctuates. There were some studies that supported the fact that nicotine might be helpful for tic severity, and there was just a lot of problems with using that intervention because of the potential long-term addiction. So it's pretty much fallen to the wayside at this point.
Dr. Deputy, we have a question on the chat.
Okay.
Let's see, hold on, it just moved down. So Dr. Patil asks, so what is the best way to control tics when on stimulant meds? Just reassurance? Guanfacine?
So that's a very good question. So let's say we're on a stimulant medicine and we know we have tics and the tics go through their exacerbations. Change your stimulant medication only if you need to change it to treat the symptoms of the ADHD. Don't change it because there's a fluctuation with tics. Ride through the tic fluctuations with the same dose of the stimulant medication and reassure the parents if they do perceive an increase in tics after starting the stimulant, that if they go for a long enough period of time and they look back, they're going to see overall there's not an overall increase.
Also, Dr. Friedman is our fellow colleague and expert in psychogenic non-epileptic seizures. He commented, he agreed that functional tics have more in common with PNES than physiologic tics.
Yes, absolutely. They're kind of like a conversion disorder. Absolutely.
What's the value of the Yale,
Global Tic Severity Score. So the question is, what's the value of the Yale Global Tic Severity Score? It's very useful for studies. It's kind of a more involved battery to go through in the office. I think the easier thing to do is a Likert scale for the severity of the tics in the office, as long as you're not doing a study or an intervention. But the value of the Yale Global Tic Severity Scale is that it not only quantifies the tics, it also looks at the functional impact of those tics on the children. So that's a useful scale, and it is pretty much the standardized scale when you're doing any kind of intervention for tics if you want to study the outcome. No, not really. I think I just kind of look at the kid. Have we gone through our education? Is there anything more we need to do there? No. Are you really having a hard time with this? Yes. A lot of times these kids will be ticking right in front of you in the office while you're examining them. They look uncomfortable. It's pretty easy to tell, I think, for the most part. Yeah, you need intervention. You just need education. Okay. Okay, thank you.
Thank you so much, Dr. Deputy.